Thank you for having me. I will go today through multiple questions that are very common for the clinical practice of radiation in the adoptive cell therapy. The first question that comes to everybody's mind is, how do we use radiation and how do we determine where to use it? And in our clinical practice at MD Anderson, we have now had over 5 years of experience since the adoption of CAR T cell therapy in treating and bridging with radiation for diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, myeloma, and the most exciting one is in leukemia. So starting first with the protocols that are ongoing right now, we have multiple prospective protocols. Some of them are industry funded, and we're trying to study not only the clinical outcome, but also the biomarkers, the T cell phenotype on how radiation is affecting patients who are being considered for bridging radiation prior to diffuse large B-cell lymphoma, follicular lymphoma, and myeloma. To that end, it is important to understand that hematological malignancies are actually very sensitive to radiation. So as opposed to when we treat it definitively, or as opposed to solid tumors, whenever we use radiation, it has to be a relatively low dose. And that comes from two facts. The first one is radiation is, in addition to the killing factor, it has a priming factor. And the second fact is that we use the immunogenic cell death here to help us with radiation. As for choosing the field, originally we always wanted to start with a local field and a small field because we went from involved field to involved site radiation therapy. But then with some data that emerged from both MD Anderson, Moffitt, Memorial Sloan Kettering, we actually noticed that a more comprehensive field of radiation would get a better outcome. Therefore, to accommodate the more comprehensive field, then we needed to accommodate a lower dose because we do not want to end up with side effects. There was another question that I was asked: how do we deal with side effects and what are the toxicities that are expected? Since we are doing priming and we are trying to go after the exhausted immune system, then when we give radiation with a lower dose, even if it is comprehensive, we did not actually experience toxicities that one would limit the dose of radiation or would decrease the outcome of those CAR T cell patients. And also to that end, when we give the radiation, we try as much as we can to avoid the bone marrow because you want to make sure not to cause pancytopenia, since the marrow that we treat often have been through so many chemotherapy, so many immunotherapy, and the disease itself, which can cause pancytopenia. So our first priority when we're giving a comprehensive field is not to avoid the marrow. Now, the dose quite often is a differential dose. For example, if I have a bulky area, then I would go with a relatively high dose, but never more than 30 gray. Even 20 gray is enough. And if I have a small dose that is a satellite lesion in many other areas, then I would go with an ultra low dose to that area because I'm only using the priming of that area rather than definitively treated with radiation. There are studies also that came recently about the toxicity that we observe with radiation, and they were all reassuring that we do not necessarily contribute to a higher cytokine release syndrome, and we do not contribute to more neurological symptoms. As a matter of fact, a Cell paper that just came recently did prove that when you use radiation, it does not have an on-target off-tumor side effects. Therefore, it is is the same mechanism that you would observe it with both radiation, chemotherapy, immunotherapy, and radiation. So in conclusion, for the toxicity, it is a safe bridging because the fields, although they might be comprehensive, but the dose is relatively low. We avoid the marrow, and we know now from multiple studies that we are not contributing to a higher cytokine release or to a higher neurological symptoms. The last and most exciting parts that we are working on right now, and you will see emerging data about, actually comes from preclinical models. In these preclinical models, they did show that, for example, if you use a total body irradiation, but only to 2 gray, in mouse models, both a leukemia or a lymphoma mouse model, we did see that these mice, when they received the 2 gray of total body irradiation, they ended up with a better fitness of the CAR T cell, a more expansion of the CAR T cells, and actually a better outcome for the tumors, even if a lower dose of CAR T was used with the radiation. That came to the same conclusion that we discussed right now, which is it is more comprehensive field, it is a lower dose, and the 2 gray total body irradiation is a very safe way or a technique that has been used in allogeneic stem cell transplant for 2 or 3 decades right now, with a very higher rate of safety. So the first application that is going to come to this is to try at MD Anderson to run a randomized trial where we give 2 gray of total body irradiation for leukemia patients prior to CAR T, particularly ALL, which is acute lymphoblastic leukemia, where we are going to compare the biomarkers, cytokines, chemokines, T cell phenotype, comparing 2 groups, the one that received total body irradiation prior to cell therapy and the one that did not. To that end, also, since we know now that CAR T can traffic into the central nervous system, which is again a very exciting finding, and since more and more in hematological malignancies, we do see that there is involvement of the central nervous system. You see it in leukemia patients because they're living longer, even with a marrow negativity. You see it in myeloma patients because now we improved the survival of these patients of almost a decade. We also see it in lymphoma patients. So because the CAR T cell with traffic, and because we already proved that radiation synergistically would work with CAR T cell to relieve the exhaustion, to increase the CD cytotoxic T cells and decrease the T regulatory cells, then we thought that from now on we're going to start applying a craniospinal irradiation for patients who are undergoing CAR T cell therapy, specifically if they have CNS leukemia. The potential benefit of that it could be applied for any other disease, including lymphoma and myeloma, to use craniospinal irradiation. Where did we get the data from? We already published our data for the benefit of craniospinal irradiation prior to all patients that would receive transplant if they have CNS leukemia or they have a high risk for CNS leukemia when they are undergoing transplant. So we wanted to transfer that same knowledge that is published to the CAR T cell world, where we would also do a randomized study where we compare patients who received CSI, which is craniospinal irradiation, to patients who did not, and then collect blood and CSF and compare it at different time points. So where I think the field is going is radiation should not be looked at anymore as a killing mechanism where it is associated with toxicity, but rather as a priming mechanism where it could help with the exhaustion of the CAR T cell therapy that has been showing that not all the patients will be in remission and many of them would fail. That priming mechanism should be very safe because we're using a lower dose, and we are very careful on how to apply the radiation. And with the modern technology that we have right now, with the computer-assisted treatment planning, you will be able to deliver the treatment to the area in need without any excess dose of radiation to the heart, lungs, breast, bowels, and you name it. And that was the promise of the modern technology, radiation therapy. But the other promise is radiation is really acting as a new drug right now. In the past, we always used to give it either as a consolidation, or if we are at the end of the road telling the patient there is nothing else we can do, we're going to give you radiation and that's it. At this point, there is a super promising role for radiation as hand in hand with not only CAR T-cell therapy, but also with immunotherapy, because many synergistic effects happens with immunotherapy, BTKI, or venetoclax, or azacitidine, or cyclophosphamide, or brentuximab. You could see that there is an amazing synergism between the two. So the future is truly going to hold radiation in that sense. The last thing that we hope to work on is, in the future, in addition to autologous CAR T cell, there will be allogeneic CAR T cells, there will be NK cell infusions, and radiation therapy would work perfectly with these, since we all know right now that biggest problem for autologous CAR T cell is the inability to collect if patients are heavily pretreated. And since everybody is moving to treat with CAR T at an earlier stage when the patients are not already exhausted, then radiation would come as a very handy, non-toxic method to help us to bridge those patients safely to get the CAR T cell, and in the future we can move it to other form of adoptive cell therapy.